Hi friends, good evening. I'm Dr. Ashutosh. And the premise of the fetal medicine is not exclusively to make a diagnosis, right? So whenever we are examining the baby, whether we are doing it in first trimester or in second trimester, we identify some abnormality, and therefore we make the provisional or we make a diagnosis, right? But then probably the whole of the sort of an area opens up by making a diagnosis. What come what may, the meaning thereby once we make a diagnosis, how sinister it is there, what more investigations that you want to do, what if the investigations they turn out to be normal, and what would be the whether we would be in a position to do a comprehensive genetic analysis, whether we would be in a position to rule out everything. What if all these things they turn out to be normal? If it is abnormal, then probably we are clear that probably we have done some tests, we've identified some abnormalities, so the decision making is easy. But if what if the comprehensive genetic analysis available, armamentarium available to us, if they turn out to be normal, then what would be the prognosis of the baby? Whether the baby would need some corrective surgeries after the baby is born? What would be the prognosis? So meaning thereby that probably the genetic counseling regarding that particular finding has to entail all these possibilities, and probably you need to touch upon all these parameters, and therefore the whole premise is to give a correct guidance and to really make them understand that probably this is the best way out, right, to our understanding, right? So micrognathia is one of the such findings across. So whenever we identify micrognathia, we need to be very very sure about the findings, and it is almost always an omnious finding, right? I have had another video on a micrognathia earlier, but came across with this thing, and therefore so probably let us go through the video and then probably we'll talk about. Now this is the fetus that we are seeing at the anomaly, and then it is at 20 weeks, and just try to look around for the mandible, and so the nasal bone and the nose and the upper lip is absolutely great, but we hardly could see the mandible, and so this is a case of an sort of a micrognathia, right? So we need to differentiate between the retrognathia and micrognathia. We do have a lot of parameters by which we can identify the mandible, but jaw index has been identified and it was wonderfully well, right? And this is the 4D live to the fetus, and therefore we hardly could see the mandible and could be peri-robin and all those stuff. So this is a case of a micrognathia, right? So jaw index has worked wonderfully well for us. So 100% sensitivity and 98.9% specific about the micrognathia, right? So this is one of the case in which we identified a micrognathia that could be associated with these syndromes, with chromosomal, this skeletal dysplasias, this chromosomal abnormalities, and so we can have non-chromosomal syndromes also, and this is the first list, and this would be second. So micrognathia is a sinister finding. It is very omniscient finding. So whenever we see a finding like micrognathia, and it is almost always an omnious finding, right? So the list is very exhaustible, and so we can have syndromes, we can have chromosomal, we can have skeletal dysplasias, we can have an huge list of non-chromosomal syndromic etiologies associated with micrognathia, and those micrognathias they probably would need, so meaning thereby that the baby would need definitely a very very comprehensive genetic analysis, and even then also the prognosis might not be that great, and the only thing is this, that they need to be, and then the baby would definitely need some surgeries, and so meaning thereby that the background sort of an abnormality, whether it is chromosomal, whether it is genetic, whether it is blood dysplasia, is definitely there. So baby micrognathia is just the sort of an finding that probably we are seeing because of that particular part, which is the background genetic abnormality, right? And that the baby would need a corrective surgery, and after the baby is born. So this is what we've identified is this, that is almost always an omnious finding, right? And so meaning thereby that the patients, that the couple, that the consultant, referring physicians, they need to be counseled regarding in the same sort of an context, right? So they could be associated with A, B, C, D. Even though we do genetic analysis, we would not be in a position to really root out all the things, almost everything. And then also, if they turn out to be abnormal, then also the baby would be. Then also, we are never sure of a sort of an and then the baby would need surgery after the baby is born in the postnatal period, right? So micrognathia is almost always an ominous finding. Um, that is it. Okay. Thank you very much for your patience.